Welcome to Examining Kidney Toxicities of Sunitinib and Imatinib in Long-Term GIST Therapy. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the LRG Senior Director of Programs, and I am your moderator for today. I would like to introduce our presenter today, Dr. Benjamin Humphreys. Dr. Humphreys is an Associate Professor of Medicine at Washington University in St. Louis School of Medicine, where he is Chief of the Division of Nephrology. He also directs the Onconephrology Clinic. He received a bachelor's degree from Harvard College and MD and PhD degrees from Case Western Reserve University. He completed a residency in internal medicine at Massachusetts General Hospital and a fellowship in nephrology at Brigham and Women's Hospital in Boston. He has had a long-standing interest in all forms of cancer-related kidney disease and in human studies. He investigates the mechanisms of kidney toxicity induced by targeted therapies, including hypertension and proteinuria in cancer patients receiving anti-VEGF therapies. I would like to now introduce Dr. Humphreys to begin this presentation. Thank you.
Well, thank you very much, Sarah, and it's a pleasure to participate today in this webcast. I will be happy to take questions at the end, so write them down or fire them off during the presentation, and let's begin. So I'm going to talk today about kidney toxicities associated with Sunitinib and Imatinib in long-term GI stromal tumor patients. I'm going to very briefly review the kidney structure because this will help you to understand the site of toxicity. And then I'm going to talk a little bit more about chronic kidney disease because that is the primary toxicity that most patients would be concerned about because it limits one's ability to be eligible to receive other chemotherapy drugs. I will spend a little while reviewing the known toxicities of Sunitinib, and then I'll talk more at the end about possible long-term toxicities of Imatinib. And without further ado, then, here is a kidney. The functional unit of the kidney is the nephron here on the right-hand side of the screen. The nephron is composed of a glomerulus, which is the filtering unit of the kidney, wherein blood flows through renal arteries and is filtered through this very delicate structure called the glomerulus to form a filtrate, and which then travels down the tubule in red, which I'm drawing, and it ultimately drains out here into the ureters and bladder as urine. Here is a higher power view of the glomerulus, this delicate structure that I was alluding to, with blood flowing in this way and flowing out that way, with primary filtrate being formed here, which will ultimately become the urine. The reason that I am highlighting this structure is that it is the site of toxicity for Sunitinib in particular. What about chronic kidney disease, or CKD, which is how I will refer to it, in the general population? It turns out that CKD is quite common. There are about 19 million patients in the United States, or almost 10% of the adult population, that has some degree of chronic kidney disease, although most of it is mild. The predominant risk factors for developing chronic kidney disease are diabetes and hypertension. And we divide chronic kidney disease up by stage. So stage 1 is really quite mild. In fact, there's a debate about whether it's a disease at all. Stage 2 is also mild, and that reflects a reduction in the filtering capacity of the kidney by about 50%. Stage 3 is clinically significant, and there are about 7 million patients in the United States that have stage 3 chronic kidney disease, and this reflects a reduction in the filtering capacity of the kidney by between 50 and 80%. Now, when you get to stages 4 and 5, that is advanced chronic kidney disease, and in stage 5 in particular, those patients are on the verge of needing dialysis. One thing to keep in mind about chronic kidney disease is that it is generally irreversible. So a patient that progresses from 2 to 3 will never regain that lost kidney function. It's permanently gone. Why do we worry about chronic kidney disease? And this is in the general population, not in cancer patients, but one of the main reasons that we worry about it is that chronic kidney disease leads to the buildup of toxins in the blood, which accelerate heart disease and increase the risk of death, primarily through heart attack or heart failure. One of the terms that I'll be using for the rest of the talk is eGFR, and that stands for Estimated Glomerular Filtration Rate, and that is one way that we measure kidney function. A normal eGFR is about 90 to 100 milliliters per minute per meter squared is the unit. And stage 3 chronic kidney disease has an eGFR between 45 and 60, stage 4, 30 to 44, and stage 5 is 15 to 29. And what you can see is with the more chronic kidney disease that a patient has, the higher the risk of death, up to 15-fold higher risk of death here with the most advanced forms of chronic kidney disease. This may not be the main concern for patients that have cancer, however. Certainly a risk of heart disease in cancer patients is not something anybody desires, but let's face it, the important thing is to keep the cancer under check. And the reason why, from my perspective, we worry about chronic kidney disease in cancer patients is primarily because once a patient's kidney function is irreversibly affected, their eligibility for clinical trials is severely limited. As some of you may be aware, investigational drugs often require that patients have a normal or nearly normal kidney function. And in the fast-moving field of cancer therapeutics, having access to these clinical trials is often a life-saving matter for patients. And so if they develop chronic kidney disease, it will limit one's ability to be considered for clinical trials in the future, and that's a very important issue. My final introductory slide just discusses about how we measure glomerular filtration rate, and I want to introduce the concept that unfortunately we don't have very good measures of kidney function, particularly when kidney function is good or just mildly declined. So GFR, as I mentioned before, is how we measure kidney function. It varies according to age, gender, body size, and it's typically even 130 or 120 for young people, and it does decline with age. We think about 1 milliliter per minute per meter squared as adults, and this is probably simply from wear and tear. We measure glomerular filtration rate with the blood test serum creatinine. I'm sure almost everybody has seen this value on your lab reports. This is the typical way we calculate glomerular filtration rate using a formula. We can also measure it using a 24-hour collection. The issue that I wanted to raise with the creatinine is that, as I alluded, it is not a very accurate way to measure chronic kidney disease. And so here are 3 different patients, a 24-year-old black man, a 63-year-old white man, and a 59-year-old white woman. And all of them have the same serum creatinine value of 1.3 milligrams per deciliter. But because they are different race, age, and sex, the actual kidney function, or GFR, that this serum creatinine value corresponds to is quite different. So the young black man has normal kidney function, and we consider anything over 60 normal. The older white man has stage 3 chronic kidney disease because he's in between 45 and 60, and the older white woman actually has considerably more severe chronic kidney disease at 45. And so when I talk about imatinib and chronic kidney disease, please keep in mind that we are limited by the fact that we don't have very accurate measures of chronic kidney disease, and that is one of the reasons why it has been difficult to tell with confidence whether long-term imatinib therapy causes kidney toxicity. Okay, so let's start off by talking about sunitinib, and this was a patient of mine from a while ago, a 41-year-old woman who had a baseline normal blood pressure of 108 over 74, and she was started on sunitinib for GI stromal tumor in October of 2002. 3 years later, she developed hypertension with a blood pressure of 140 over 98, which then worsened to 154 over 102, and she was started on 2 blood pressure medications, and then a third. And then she was found to have proteinuria, which is when protein leaks into the urine, which it normally should not do. So what we did together with the oncologist was increase the washout period for sunitinib to 4 weeks, followed by a dose reduction, and her blood pressure improved and her urine protein fell. Here in the next slide is examples of how some patients respond to being started on sunitinib, because hypertension is a very common side effect of sunitinib. And on the left-hand side here, you can see a patient who during one 3-week cycle had her mean arterial pressure, this is that same patient actually, increased. This is like her average blood pressure from 80 to 110. And over here are groups of patients on the right-hand side who, while they're on sunitinib, you can see have this increasing trend of blood pressure that then falls when they come off of their sunitinib cycle, which then increases again. So what is this all about? Well, here was a study that we did using a different anti-VEGF therapy rather than sunitinib, but one that's similar called cediranib. And these were patients with ovarian cancer. And this is just to show you that over the course of this 8-week study, there were over 80% of patients who developed hypertension compared to 25% at the beginning of the study. And 70% of these patients required the addition of antihypertensive medications. And so this was very common. And here again we can see each individual patient in the trial and the magnitude of the hypertension that they developed. The point being that hypertension is a very common side effect of drugs like sunitinib. Why does hypertension occur? And I won't go too much into the details, but I do just want to show you this old study where investigators measured the blood pressure, mean arterial pressure, and heart rate of an experimental rabbit in this case. And when they administered a vascular endothelial growth factor, which is the drug that which sunitinib targets the VEGF receptor, what you can see is that there's a fall, an immediate fall in blood pressure that is reversed with this inhibitor of nitric oxide. And so the opposite happens when we give sunitinib, because instead of giving VEGF, we block VEGF and blood pressure rises. And that's what's happening in humans. How do we manage hypertension caused by sunitinib? We do it very much in the same way that we do with patients who don't have cancer. We take a history and look for other risk factors, physical exam, we will do some labs, and then begin antihypertensive therapy if patients are not controlled. And then after they begin anti-Angiogenic therapy, which would be Sutent, regular monitoring is critical, and I encourage my patients to buy a home blood pressure monitoring cuff at CVS. They cost about $30, and they're quite accurate. And then we treat this hypertension as needed, and we do not increase the sunitinib dose unless blood pressure is controlled. In my clinical experience, in the vast majority of cases, we can control the blood pressure of patients who develop hypertension or exacerbated hypertension while on sunitinib or similar drugs, so that they can continue taking their therapy. Okay, I just wanted to raise one question, which is a sort of an open question, but basically there is a school of thought which has argued that hypertension may not even be a bad thing, because what it tells us is that patients are getting enough drug to inhibit their VEGF receptor. And so if they're getting hypertension, that means that their cancer is also receiving enough drug to block VEGF. And so there have been a couple studies. This is one from Brian Renal, who looked at, in renal cell carcinoma, patients who developed hypertension in this line right here versus did not develop hypertension. And this is looking at survival. And there was a difference in overall survival between patients who developed hypertension and didn't. And so what we think is that possibly this is what we call a pharmacodynamic biomarker, or just an indicator that patients are getting enough drug if they develop hypertension. I want to stress, though, that this has not been investigated in GI stromal tumor, and it remains a somewhat controversial area. But the take-home message is that if you do develop hypertension or even proteinuria while on sunitinib, it's certainly in everybody's interest to try and manage that so you can remain on the sunitinib. What about proteinuria or protein leakage? This is another patient of mine who also had GI stromal tumor. She was an older woman, and this is a graph looking at the amount of protein in her urine. And normally, the glomerulus, that structure that I showed you earlier, doesn't allow protein to leak into the urine. And you can see that at this point, this patient had 0 protein in her urine. She was on sunitinib, however, for almost a year. This is 50 weeks. And she developed 10 grams of protein while on sunitinib. And this is a very high amount, and it caused her to develop edema. She also had a very high blood pressure. And so she came off of the sunitinib, and you can see that her protein levels then recovered back down almost to normal, if not completely normal. And then at a later time point, she went back on another drug called sorafenib, which is similar to sunitinib, and immediately developed this same amount of protein again. And so what's going on with proteinuria, which is another known toxicity of sunitinib? Well, we also looked in this group of patients who were being treated for ovarian cancer with Sunitinib, which is a drug that's similar to Sunitinib. And we asked the question, how many of them developed new proteinuria? And the answer was, over the course of the study at baseline, none of the patients had proteinuria, but by the end of the 6-week study, 30% of patients had proteinuria on their dipstick, although we didn't quantitate it any more than that. So this is a relatively common side effect. It's also one that we can manage pretty well. I just want to give you a sense of why we think proteinuria occurs in patients that are treated with these drugs. This is a electron micrographed cross-section of the glomerular capillary. And remember, the glomerular is that ball-like structure where the blood passes through in here. Red blood cells pass through the middle of this capillary, and filtrate is formed going across this capillary membrane. And so albumin and protein stays in the middle of this capillary, and water and solutes pass through it. And the reason why protein stays inside is shown here on the right-hand side, because there is this very delicate thin slit diaphragm which serves as a block for protein so that protein cannot get through. And I just want you to see how wide and open this capillary is, and then compare it to a patient of mine who we biopsied who was receiving Sunitinib, and look at how different this is. You notice here is the lumen of that capillary. It's very small and narrow, and you can imagine it would be hard for blood to pass through. And it also damages this filtration barrier, which allows protein to leak into the urine. And so this is why we think patients develop proteinuria. Fortunately, this proteinuria is largely manageable with blood pressure medications, and we do that using a variety of blood pressure medications like lisinopril or angiotensin receptor blockers, as well as diuretics and calcium channel blockers. In patients that I follow who develop proteinuria, we monitor urine protein, but I don't necessarily ask an oncologist to take them off of the drug, because many patients do very well for quite a long time, even if they develop protein leakage. I do get concerned if their creatinine begins to rise, however, and that's when I will call the oncologist and suggest that we might want to think about a drug holiday. Okay, what about imatinib and chronic kidney toxicity? And I just want to say at the outset that this is an area that is still being investigated, and I would have to say that there's no consensus about whether this is even a true phenomenon. But I'm going to review all the data on this topic, and I'll also share with you my own experience with seeing long-term GI stromal tumor patients who had been treated in George Dimitri's original phase 1 trial. So these patients had all been on Gleevec for greater than 10 years, and Dr. Dimitri was kind enough to refer these patients to me so that we could analyze the 16 who were still on the protocol. 15 out of these 16 had normal renal function at the start of therapy, and over these 10 years, 10 out of 16 developed chronic kidney disease while on therapy, and one of them actually progressed to end-stage renal failure. All of them experienced a fall in their estimated glomerular filtration rates. Remember, that's kidney function. That was greater than we would have expected from just age alone. And that is summarized right here. You can just focus on the red box. So these were the decline rate in kidney function on a yearly basis was about minus 2.5 milliliters per meter squared for patients on Gleevec, and this is compared to our expected rate of decline of somewhere between 0.5 and 1 milliliter per minute per meter squared. And so basically this is about 3-fold higher loss of kidney function than we would have expected just from aging in these patients who had been on imatinib for a long time. Here are some of the individual patients, and this is all, I should say, unpublished data, so it has not gone through peer review, but I just want to share with you our experience with it. Here was a young woman who actually experienced between ages 18 and 28 a fall in her renal function over the years to the point where she actually had chronic kidney disease stage 3. So that's significant for this young woman with GI stromal tumor. And here are 3 other patients of varying ages who also had a substantial fall in their kidney function to below this level of 60, which means that they do have chronic kidney disease stage 3. What have other investigators published concerning chronic kidney disease and imatinib? Well, as you all probably know, the other group who has first-line therapy for imatinib is chronic myelogenous leukemia, CML patients. And so Marcolino and colleagues about 5 years ago published their experience with 105 CML patients analyzed. These patients were on imatinib for about 4.5 years, so not as long as the patients from Dr. Dimitri that I showed you in the prior slide, but still on therapy for quite a while. What they found is that 7% of patients developed an episode of acute kidney injury, and by acute kidney injury, what we really are referring to is an insult that is reversible. But 12% developed chronic kidney disease, and by that we mean an irreversible, permanent loss in kidney function, which is reflected by both a rise in their serum creatinine measured in the blood and a fall in the calculated eGFR. The average age of these patients was about 50 at the start of therapy, and look at this, the mean decline in glomerular filtration rate of 2.77 was very similar to the rate that we witnessed in our own study at Dana-Farber. So I think this data is supportive of the experience that we saw ourselves. Another study came out just last year, and this is the largest study that I am aware of examining kidney function in CML patients. So Yilmaz and colleagues analyzed 468 CML patients. The median follow-up was actually, again, not very long, 52 months, so about almost 4.5 years. There was a rate of acute reversible acute kidney injury of about 4%, and 14% of these patients developed chronic kidney disease, irreversible kidney disease. And this was associated primarily with imatinib. There were also some patients on nilotinib in this study, but smaller numbers. Risk factors for developing chronic kidney disease were age, hypertension, and diabetes, and that's not surprising because those are all risk factors for developing chronic kidney disease from any cause. Very importantly, I think for patients with GI stromal tumor to know, even though these patients did develop chronic kidney disease, what these authors report is that there was no impact of kidney injury, whether acute or chronic, on cancer response. So they still remained responsive from a GIST perspective to the drug. More recently, just this year actually, Vidal-Petiot published a very provocative study suggesting that this, what we're calling chronic kidney disease, is all basically an artifact. And what they're saying is that imatinib causes an artificial rise in serum creatinine, which does not reflect kidney failure, but is just because imatinib inhibits the tubular secretion of creatinine in the kidney. And so the way they performed this study was examining a small number of patients using a different method, what we call a gold standard method, using 51 chromium EDTA. It's a nuclear test to measure kidney function. And what they found is that these 4 patients who started imatinib experienced an 18% increase in their serum creatinine that was reversible. And in the next slide, you can see in 15 other patients, the serum creatinine value in patients before they started and while they were on imatinib and after they stopped imatinib in the gray bars, and in some cases in the white bars after they restarted. And so you can see this U shape right here. And so again, what the authors are arguing is that this is essentially like a lab artifact. But the point that I want to make to you all is I think this data probably is accurate, but we're talking about very small changes, 18%. So from a creatinine of 1 to 1.2, and this really does not reflect a substantial change in the calculated GFR. And so while I believe this study is true, I don't think that this is an explanation that can make us feel comfortable that long-term imatinib therapy isn't actually truly associated with real chronic kidney disease. And so, in summary, in my opinion, long-term, over many years, and here we're talking 5+, long-term use of imatinib is probably associated with chronic kidney disease in some patients. And I'm really leaving this purposefully general and vague because this is a new area and we just don't have enough data to be confident enough about this. Nevertheless, I do believe this is a real phenomenon. We don't understand the mechanism at all, and we don't particularly understand the risk factors, although I think it's safe to assume that time on therapy, age of the patient, presence of diabetes, and presence of hypertension are probably going to be important risk factors. But mainly, we do need larger studies, and this area remains controversial. And I have had conversations with some CML oncologists who have treated hundreds and hundreds of patients with imatinib who don't actually believe that this is a real thing. And so I just want to really stress that this is a changing field that still has controversy. What about this question? And I saw that somebody even asked this in the chat room. Obviously, GIST patients do receive frequent CT scans, and they often have contrast, iodinated contrast, to stage their tumor. And as everybody probably knows, CT scans with contrast can cause acute kidney injury or reversible damage to the kidneys. And the risk factors for this include patients who have pre-existing CKD, diabetes, the elderly, and those who have heart failure. The question, though, about whether regular CT scans 2 or 4 times a year could actually cause new CKD is one which, as a nephrologist, as a kidney specialist, I don't believe is an adequate explanation for the kinds of kidney disease that we're seeing in long-term survivors. And the reason is that lots of different survivors get frequent CT scans, but there's been no reports of chronic kidney disease in 10 or 15% of patients, as there have in patients who've received long-term imatinib. So I think on balance, it's very unlikely that regular CT scans are an alternative explanation for the chronic kidney disease that we see. As patients, what can you do to protect your kidneys? Well, it's very important to have any hypertension treated, because high blood pressure causes a stress on the kidney, and that will accelerate damage. If you have diabetes, it's important for that diabetes to be managed well and to keep your sugars low. If you have hypercholesterolemia, that needs to be treated as well. And if you take regular non-steroidal anti-inflammatory drugs like Motrin, Aleve, ibuprofen, those can be quite tough on your kidney. And so what I tell my patients is, if you have a headache or a migraine or your knee is aching, it's fine to take 1 or 2 pills every now and then, but I really don't want you taking it every day for a week. And you'd be surprised, because these are over-the-counter medications, some patients just assume that they are safe, but when taken over time in a consistent fashion, they actually are quite toxic to the kidneys. So in summary, and then I'll be very happy to take questions, I think the most important piece of good news, and you all know this better than I, is that GIST patients are living longer by and large and have many more treatment options than they used to. As a consequence of this therapeutic success, many patients are on these drugs for years, and the concept that it's more of a chronic disease now than an acute emergency is one which allows a longer time frame for toxicities to develop, and it does appear that we need to keep our eye, I think, particularly on the known toxicities of Sunitinib, hypertension and proteinuria, but also of imatinib, because, as I mentioned before, fortunately, this toxicity of imatinib is relatively slowly progressive, and so we can detect it with plenty of time, but it is permanent. And so when patients have chronic kidney disease, they may be ineligible for future new discoveries that might help manage their cancer in the future if they do develop chronic kidney disease. And so with that, I'll stop. I'll be very happy to take questions, and I do want to acknowledge Dr. Dimitri, who really, as you all know, is a pioneer in this area and was nice enough to share his patients with me, and Dr. George, with whom I also shared a lot of patients, and I think is known to some of you at LifeRaft. So thank you very much, and I'll be happy to take questions on the chat board.
Thank you very much, Dr. Humphreys. This was an excellent and informative presentation, one that I think many of us have not heard before, so I'm glad that we had the opportunity to introduce it to the patient community. Okay, so for the first question, the participant asked, is stage 1 kidney disease reversible?
Yeah, so this is a good question, and so let me just talk about that a little bit more. There's an internal debate within my community of nephrologists whether stage 1 kidney disease is even a real entity, and that is because of what I mentioned before, and that is that serum creatinine is an imperfect measure of kidney function, particularly when the kidney dysfunction is very mild. And so to call somebody, to say to a patient, you have stage 1 chronic kidney disease, is actually, it may be difficult, particularly if they're older, because we do not know if that's real kidney disease or if that's normal human aging, because we do lose kidney function year over year from normal aging. So my general response to this would be stage 1 chronic kidney disease probably is reversible, if only because we really are not convinced, and I'm not convinced, that it's truly a disease. When you get to stage 3 with an eGFR of less than 60, that for sure is real chronic kidney disease that is irreversible. Stage 1 and to some extent perhaps even early stage 2 may be reversible and may not even be real disease.
Thank you very much. What about avoiding protein pump inhibitors?
Well, protein pump inhibitors have been in the news lately because they are associated with basically a chronic allergic reaction in the kidneys, which can also lead to chronic kidney disease. And the issue is that so many patients are on these that even though it is a rare complication, the numbers actually add up to a lot of people just because millions of patients take proton pump inhibitors. And so my response to that question would be that if you truly have gastroesophageal reflux disease diagnosed by your primary care physician and the proton pump inhibitors help control the disease, then I think you should take that medication because it's effective with continued monitoring of your kidney function. But if you're just buying it over the counter, then I think that's a conversation that you should probably have with your primary care physician first.
Very good. Thank you very much. So the next question is, a lot are coming in, so let me get through them. I've been on Gleevec 10 years. Is standard lab work showing GFR sufficient for monitoring this, or is there some way to get a better baseline?
Okay, that's another good question. And in general, the standard lab work that you receive at your, twice yearly or even maybe once yearly if you've been on it for 10 years, lab work, which will include serum creatinine, that is sufficient. You could potentially also have a urinalysis, which would detect protein leakage, and that is likely a part of your yearly visit. But the most important thing is to get that Chem7, which includes serum creatinine, and that allows your provider to calculate eGFR and determine if it fell to below 60. That being said, I showed you our own experience. Even when patients do develop chronic kidney disease, if they are continuing to experience control of their disease, of their GIST, despite developing chronic kidney disease on imatinib, we usually leave patients on it because we want to control the cancer. And this kidney toxicity is only slowly progressive.
Okay, very good. Thank you very much. Are there any physical signs of kidney disease?
Well, there are, but unfortunately not until it is quite advanced. And so, like hypertension, kidney disease is largely silent to patients that develop it. The types of things to look out for are swelling in your ankles, particularly if you have a high salt meal, or potentially developing a high blood pressure, although that's not a symptom, that's something that needs to be measured. At more severe levels of kidney disease, patients can develop substantial fatigue and need to take naps during the middle of the day, low energy, metallic taste in their mouth, poor appetite. But those are at stages 4 and even stage 5, levels where your provider would clearly have seen that your creatinine was very abnormal at that point in time.
Okay, very good. Thank you very much. There's a cluster of questions that fall under this topic of how to protect kidneys, like are there certain foods or drinks that should be avoided, like alcohol? Or also on the flip side, are there any dietary or supplemental recommendations, acupuncture, that sort of thing?
Okay, well, this is a great question, and many of my patients ask me this question on a regular basis. And so in terms of diet, I recommend a Mediterranean-style diet. There is some evidence that a diet high in red meat accelerates kidney dysfunction. And so I recommend to my patients that they eat 7 servings of fruits and vegetables a day. It's a lot. It's actually hard to do. And to have nuts and whole grains, olive oil rather than butter or saturated fat, whole grain bread instead of white bread, avoid processed meats, try to choose chicken or fish rather than pork or red meat, although it doesn't mean you can't enjoy a steak every now and then, but really try not to have it every day. Regular exercise, like everything, is healthy for your kidneys as well as your heart and other organs. Some patients do take supplements, and I generally discourage that unless you know where they come from. There is something called Chinese herb nephropathy, which is thought to be due to toxins that are present in certain Chinese herbs that are prevalent not in the United States but actually in China. But that has caused a sort of a rash of chronic kidney disease. And in terms of fluid intake, you should probably try to have 6 or 8 glasses of water a day, but the data there are less strong that low fluid intake actually leads to chronic kidney disease. So if you just try to drink when you're thirsty, you'll probably be just fine.
And the alcohol question as well?
So for alcohol, it's not something that you should start drinking if you're not already enjoy a glass of wine, for example. But for women, 1 alcoholic beverage a day, and for men, 1 to 2, has cardiovascular benefits that are probably also beneficial to the kidney. And so moderate alcohol intake has no adverse effect on the kidney. It's not like heavy alcohol intake is obviously bad for the liver and can cause cirrhosis, but the same is not true. So don't start just to be protective, but if you already enjoy a glass for women or a glass to 2 glasses for men, that's just fine.
Okay, very good. Thank you very much. Next question. At what stage of CKD would you consider decreasing the dose of imatinib, particularly if it is being used in the adjuvant setting?
This is a very difficult question, and each case is an individual case, and so I think that's always a conversation between the nephrologist and the oncologist and the patient, and it has to do with several factors. From my perspective, as a person who wants to protect the kidneys, I want to know how fast is kidney function deteriorating, and I also want to know what stage. So if we're in stage 4 kidney disease, which an estimated glomerular filtration rate less than 45, that's when I would really want to have that conversation with the oncologist, and I would want to say, what other therapies can you offer to this patient, or is this it? Is this the only therapy that you think is going to be effective? If there are other therapies, then I might say, well, why don't we consider stopping imatinib for now, and if you're comfortable starting a new drug, go ahead and do that. On the other hand, if it's if there's no viable alternative, then we typically continue it. And as you could see, for some of those patients, particularly that a young woman, we just continue the drug because it's controlling the disease, and we don't want patients to have progression of their cancer. So it's a tough question. I think it's an individual question, but that's the way that I approach it.
Okay, very good. Thank you. Next question is, should I ask for more detailed regular kidney tests other than the creatinine level monitoring?
No, I don't think you should ask for more any additional testing. If you have developed chronic kidney disease, whether it's from imatinib or something else, then you probably do need more than once yearly monitoring. I would suggest twice yearly at least, and if you have more advanced chronic kidney disease, then once a quarter. But that serum creatinine is all you need.
Okay, very good. One last question. Somebody was asking as a follow-up to the supplements question about using Metamucil and glutamine and probiotics, if that's okay to take.
Metamucil and probiotics are just fine. Glutamine is probably okay as long as you're not taking very large quantities. Some folks, for example, weightlifters sometimes take very large supplements, protein supplements or amino acid supplements or things like glutamine, and that actually can be very hard on the kidney. But if you're just taking it as almost like a vitamin type of supplement, it should be fine.
Okay, great. Sorry, one more slipped in. Last one. Are there any studies considering kidney disease and regorafenib?
So regorafenib is, let's see if I'm remembering correctly, is similar to Sunitinib, and Dr. George has done some investigation of regorafenib and GIST and toxicities, and so I believe that the toxicities are similar to Sunitinib. In other words, hypertension and proteinuria. So I would combine those into the same category.
Okay, very good. A lot of great questions today, and thank you very much for addressing them. So we're going to be ending this webcast for today. We will be placing the recording, the archive, on our website shortly, so please stay tuned for that. I want to thank Dr. Humphreys for his time today and providing a very excellent presentation to the group. We really enjoyed it, and we want to thank you for your time today. Everybody have a wonderful day.
Okay, thank you. Thank you very much.
Thanks.